All right. I'm joined here with Dr. Baraki. Austin, what's going on, man?
Not much. How are you?
Great. I'm living the dream. Just got back from the gym and same. It's a nice evening to record a podcast, but I thought we'd discuss some SteadyMD stuff first because we've been getting a lot of questions on what exactly we're doing with SteadyMD. What is it? How this compares to like a quote unquote regular doctor. So just question to you. How do you foresee your interactions going with patients within SteadyMD?
I think to kind of preface this, the way that it's going to be set up is that it sort of is arranged in a way that allows you to have a long-term relationship with a physician. And the way the system is designed is that the physician will maintain a relatively small panel of patients that they're taking care of, whereas you might have a typical primary care physician in charge of 2,000 patients in a freestanding clinic. We're gonna cap our patient panels at somewhere around 500 patients or so. And the idea of that is that it'll allow us to have more access and more time to devote to common patient issues. Additionally, the system is set up so that they have kind of direct access to the physician through like a private chat app kind of thing. And so, the initial meeting helps the doctor get to know the patient and get to know their issues, their health goals, their health problems, things they need to work on. And over time, you'll have regular contact with your physician in order to help you, reach those particular goals. So, both of us do a lot of coaching in person and remotely. And so with our remote coaching that we do with lifters, for example, a lot of them have very regular contact with us. They can shoot us a message anytime, say this lift is feeling like this, or I'm not feeling too good today, or I had this injury happen, or things like that. And so we're able to help them through those issues when they send us these messages. And so I kind of foresee a similar setup with these patients when it comes time to their health issues as to what we do. It's kind of like a health coaching type setup where you're able to have a long-term relationship and get patients where they want to be.
Yeah, I agree. The thing with SteadyMD, the thing that was so appealing is that you actually, since you do have a smaller patient panel, you get to spend way more time with folks actually sussing out the details of their concerns, of their health goals, their history, the whole deal. You're basically putting out fires with the regular primary care doctor, or you're actually the quote unquote gatekeeper for referrals. And I know that's always the distracting question on an exam, like, oh, what does primary care doctors do? But in reality, this is how it works. People come into the office, they need a med refill, they have one problem that you get to maybe talk about, and then you give them a referral, and then they're happy. You need to come back in a few weeks, and you never get to discuss fitness or initiation of sort of modifications in lifestyle to actually help them out. And I don't see a solution to the problem in a regular practice. So yeah, SteadyMD super forward thinking to kind of do that. And the other thing is this: there's such a demand, which is why the remote access thing is very, very useful. And we can order prescriptions, we can order labs, we can do a lot of cool things that people may think, oh, well, what can these guys actually do? We can pretty much do everything except for lay hands on you, unless we happen to be making a tour.
Which is probably going to be in the plan. I mean, I think that you would agree. I think you would agree that most of the common issues nowadays, I would say the non-acute issues nowadays that need to be managed in a primary care clinic, meaning chronic issues, weight management, endocrine issues, things like that, they require more than a 5 to 10 minute appointment. And if you really want to manage things like obesity and diabetes, more than just say titrating someone's insulin dosage, you need a lot of time to individualize the approach, to figure out what makes people tick and kind of where their issues are in the process that they might need some more guidance to help them get through so that they can get where they want to be.
Yeah, I actually, it's funny. I actually thought, or I had a discussion with a resident while I was still in residency. And she was like, no, I think you can do everything in 20 minutes. And that resonated with me, that like, you are not prepared to take care of people because you cannot do hardly anything in 20 minutes. And I don't care if you're the best diagnostician, in the world. It's just people are more complicated. Human psychology is more complicated than that. and being able to actually explain stuff to people in a way that they understand just takes longer than 20 minutes. So.
Right. Yeah. Where I can see her claim coming from.
Now you're ENTPing me.
Right. Where I can see her claim coming from is for people who have, say, for example, multiple known chronic diagnoses. And the goal of her 20-minute appointment is to ensure that the patient is on all of the quote unquote guideline directed medical therapy. That's like the magic phrase, for example, in cardiology, the GDMT, guideline directed medical therapy, to make sure that your patient who has heart failure or CHF is on this med, and their doses have been maximized. That is something that can oftentimes be done in that brief of an appointment, but that is not what we're trying to do here, and that's not necessarily what we're talking about.
Yeah, exactly. So you're basically saying that if there are guidelines for medical management, then you can do that within a 20-minute visit. But
yeah, if I have a patient who has known cirrhosis, I know what medicines to get them on. If they have COPD, I can get them on the right meds, or CHF or diabetes or whatever. I know what medicines they need to be on, and I can titrate that over time. But I don't have time to counsel them on how to live with their condition as effectively as I otherwise could with more time.
Yeah. And you know what the most frustrating thing is too? So imagine you are meeting a patient for the first time. They schedule you for a long H&P, and you have 35, 40 minutes with them or whatever, right? Optimistically, because they showed up on time, they got checked in on time, you're not running behind, everything else. Yeah. And you're going through their medical history, you're going through their surgical history, the whole deal. Medications are on, allergies, the whole gig. And then you're like, what do you do for exercise? And they're like, I don't actually do any exercise, but I'm really wanting to start. And so our eyes light up, and we're like, oh.
The unicorn patient.
The unicorn patient. Yeah, not only that, but, let's even say the non-unicorn patient who you talk about it, and they're like, hey, I'd be willing to try that. You don't have the time to discuss, hey, here's what you need to do, and, here's who you need to go see, or here's, the gym is actually attached to the clinic. You need to go see Scott, because that actually doesn't exist yet. Best case scenario, you get a referral to PT, which, right. Yeah, is not indicated. And then worst case scenario is
the referral would probably be rejected.
Yeah, the referral would be rejected. Right. Yeah.
Because they're like, what's the diagnosis? And
therapeutic exercise or something. So best case scenario, you get referred to PT. Worst case scenario, no, they don't even mention it. All right. And then in the middle is just walk more, which currently not guideline directed. So I think overall that's a huge time thing in addition to teaching for primary care. But turns out you and I may be leading the charge. Well, yeah, we have the time with SteadyMD, but also leading the charge with UpToDate. So that's going to be cool.
Yeah. You want to tell people about what UpToDate is?
Yeah. So we'll cut this and then make it something pretty. Yeah, so the UpToDate thing is super interesting. If you're not familiar with UpToDate, it is probably the largest repository of information that physicians and healthcare professionals access to guide management and to learn about stuff on the fly. So, if you're in the hospital and you have a patient who comes in with some weird disease, let's call it Chagas, the first thing you do isn't to Google Chagas, it's to go on UpToDate and put in Chagas. It's like the doctor's Google, right? And so other healthcare professionals use that as well. And it basically comes up with, for each disease or condition or medication or something else like that, it's what is it, what's the, what is the epidemiology about it? What do you do about it? How do you test for it? How do you, what's your differential? Everything we know about it. So when we were approached to write about strength training in primary care and the health benefits of, our eyes just got so, we've turned into Bambi. It's just... And because you and I know like how powerful that could be. We could have a whole page on health benefits of strength training, and then that would have to spin off to what is strength training, and that would have to spin off into what are the recommendations for strength training, and that would spin off to patient information for strength training. So
it's going to become a whole section. I foresee that it has the potential to become a whole like subsection within this just encyclopedic volume of medical knowledge.
Yeah. And then it'll be like, beyond the basics for patients. So that's the handouts that your doctors give you. That's going to be it. Like we're going to have the opportunity to influence what that is for exercise recommendations from primary care. And I mean, honestly, I don't know of a bigger opportunity that's come across our path just yet.
Yeah, I think I would agree because, when it comes to not even you mentioned the weird diagnoses like Chagas, but it's routinely used for the not weird diagnoses either. When somebody comes in with any particular problem and you just want to, just make sure you check to see that you're not missing something, or residents along the way who maybe they've only seen an asthma exacerbation for the second or third time and it hasn't quite sunken in yet. And how do I manage this? They'll use it to look it up. And so, this is something where it's going to be the first thing that people see, and people, I would guess that probably more physicians and medical folks go there to get their advice on, initial management of things. More often than they go to the primary guidelines that are published by the official organizations, because usually the guideline documents are like 175 pages, and they take a lot of time. They're oftentimes worth reading through, but they're very dense and take a lot of time. And so when you're in the middle of a day in practice in clinic or in a hospital, that's why more people lean towards this. And so that's where I think this is going to be powerful, because of its accessibility and the fact that people actually use it.
Yep, 100%. I got some Q&As from people sliding in my DMs. Yeah, so Lorraine Baraki, she's half of the doctors Baraki, first of their name. She's actually a sexual therapist. No, she is an OB/GYN resident, which means she deals with lady things. Is there anything else to you? Is that it?
That's really it. It's really unidimensional. All the lady things you don't want to think about. Yep. Me. I'm all over it.
It's funny because I had 1 month of OB and then 2 weeks of NICU, and I'm good. I think
you're pretty much an expert.
I'm pretty much an expert, and honestly, in family medicine, we do a lot of that routine female maintenance. And
female maintenance.
Yeah, you're basically like cars.
It's like tuning them up.
Yeah. Tuning them up. Look at that look of disdain. Yeah, that's love. That's love. Okay, so Lorraine, now you're a fairly accomplished lifter, much to the disdain of other females, because seemingly you come out of nowhere and decide to squat PRs just after like a 3-month deload.
Literally like 8 workouts, but whatever.
Yeah, turns out. Now, so what's your athletic background?
I played soccer when I was in high school, and I ran track and field, the shorter sprint distances. And then when I transitioned from high school to college, I ultimately joined ROTC, the Reserve Officer Corps, to get a scholarship to join the Army. And in that time, I had to run more, and then I got really into running. So then I started doing half marathons, 10Ks, things like that, and was just like a cardio junkie at that time. And then I transitioned to doing little HIIT workouts and things, whatever I could do in my living room. I was really into that for a while. And then I added weights to it by messing around with CrossFit, and thought that was fun for a little while. Don't make that face.
Oh, sorry. I just had a stroke when you said CrossFit. Every time, it's a coagulopathic term.
Just
it's a procoagulant.
It's a procoagulant. Yeah, estrogen, CrossFit.
I did little baby competitions locally, and then really got to liking the Olympic lifts, and so I just focused on those two things for a little while. Again, competed locally, I think in Richmond once, and then in Norfolk once, and thought, this is pretty tedious. I just want to be strong. And
wait. You're suggesting that on your own volition that you just decided you wanted to be strong.
Just wanted to be strong, damn it.
You didn't influence her, Austin?
So we met in med school first year, and
I'm aware.
The whole time oh yeah, I forgot about that.
Red dog.
She was
fun fact, everyone. The only reason that Austin and I met, this is not true. The town's small enough, we would have figured it out that we were the only two guys looking down when we squatted. So we would have found each other, not by looking up, but just would have. We would have found each other
together.
The first time I met Austin, I'm in a bar. Granted, I've been in Norfolk where I went to medical school. We went to medical school for about a week, right? I didn't know anybody, I see this girl at the bar, and she looks, moderately muscled, and I said to myself, she'd go up and say hello. And in a nice way, I was just, talking. And all of a sudden, out of nowhere, Austin, less 20 pounds, rolls up and is like, hey, how's it going?
Probably less 40 pounds at that point, dude.
Yeah, I was giving you some credit. I wasn't, But, yeah, so anyway, that's how I met Austin, by hitting on his girlfriend. And again, in my defense, I didn't know. It's not like I knowingly.
That's true.
Yeah, I didn't check.
You saw the muscles. They were attached to a female.
Yeah.
Proceeded.
Yeah. Sue me.
Yeah, so at that point she was running like the whole time we were dating, and then she saw me training in my garage at one point and was like, "Hey, deadlifting, do you want to teach me how to do that?" And I was like, "Okay." So I taught her, and then, there wasn't any convincing or any of that kind of stuff, because we typically advise people against that. But
oh yeah. Yeah, you're not supposed to like coach people that you're
Sleeping with?
Yeah. Yes. That's where I was going. In any event, so good. That all worked out. You guys have a bunch of cute engagements and now wedding pictures, and now you guys are just living the dream in Texas.
A marriage.
Oh, yeah. No, yeah.
And then she squatted 315 without training, so that was cool.
Yeah, you should keep her.
Yeah.
You should keep her. Hey, honestly, Lorraine, if you just don't train for like another 6 months, you'll probably squat 405. I think that's
done.
If you did the trend line.
Yeah, what are you, 52 kilos now? Are you like
No way.
Are you a junior lifter? Like, they don't have a weight class for you anymore. You have to go back.
No.
She lost all her weight during intern year, and then has
gained it all back.
since recovered. So that's a good thing. Yeah, that's a good thing.
But on a serious note, Lorraine's a OBGYN resident, so she, is big into female health and delivering babies and all that sort of stuff. So just a very pressing question while we have you. Okay.
Ooh.
What would you say your biggest source of frustration is when it comes to pregnancy and the current exercise recommendations?
That there are none.
Ooh.
That's a big frustration.
So the American College of Obstetrics and Gynecology, known as ACOG, effectively doles out the recommendations that you guys kind of make your recommendations from to the patient.
Right.
And so their current exercise guidelines are effectively like, do whatever you want.
Maybe do it. I mean, you should do it. We think you should do it. We're not going to tell you how to do it
What
or what's
accent is that?
best. This just might really.
That's the ACOG
disgruntled
accent.
accent. Yeah.
Okay. But
let me not talk trash about ACOG, because I'm in the running for the Armed Forces District Section Vice Chair this year. So
that's like way too many qualifiers. I feel like it's not important. No.
But it could be me, man. It could be me. This is my chance. But yeah, you're right. It doesn't give specific details, and basically it's telling a group of obstetricians that your patients should stay within certain weight gain brackets based on their pre-pregnancy BMI and things like that. Okay. That the mainstays should be focusing on their diet and maintaining some level of physical activity throughout their pregnancy. But as well as we do that we all go to medical school and we don't get great training on what is proper nutrition and how should someone go about tailoring or structuring their physical activity for certain goals and things like that. And it's just like what you said, they should just kind of walk and then do this intensity exercise for this many minutes, things like that. But that's all we have in medical school. But the ACOG does not give specific recommendations. They don't say don't lift weights, but they don't say do lift weights. They don't say walk, run, anything like that.
Well, they actually that's actually new, but they changed that recently. So it used to say like don't lift weights, and then right. I think it was 3 or 4 years ago they actually changed it to say you can lift weights if you like to.
Yeah. Basically, what a lot of obstetricians will tell their patients is whatever you were doing before pregnancy is probably okay, but don't try to PR. Don't try to overdo it.
But why?
There's no reason. There is no reason.
Yeah. So at the same time, though, there's no evidence, but there's no
evidence. I know.
There's no.
And pregnancy is tricky. This group of physicians is going to be really hesitant to push for something that has not been studied, and these things are likely not going to be studied in a robust, effective way when it comes to pregnancy.
Sure.
And that's just across the board.
That's probably kind of the history of their guidelines on a number of things, is generally being about as risk averse as you can possibly be, which to an extent is understandable given how devastating, say, a miscarriage can be. But it's also difficult to study a lot of things in a robust enough way to where you can confidently say this outcome say you had a miscarriage, for example, was or was not actually related to the thing that we were studying, whatever that variable is.
So we hang our hat a lot on expert opinion. But my question is,
who's the expert?
What are experts at?
No expert.
And do they even lift? I mean,
no, they don't. Yeah, well, yeah. So that's a great point. There's not like a bunch of strength and conditioning coaches who are also trained in medically trained who are saying, oh, pregnant women should or shouldn't train. It's more just doctors who have this theoretical sort of risk profile that they're thinking about associated with lifting. And what's interesting is that even Rip, has a similar view. His thing is, the type of person you don't need in your gym, pregnant woman. And his thing is that you should, if they were lifting before, you already knew them, that's fine. But if they just presented to your gym and they were a couple months pregnant, that you don't need that.
Right.
I mean, okay, I get it. But I think it's important to take home that we don't have any evidence to suggest that lifting and even starting a lifting program while pregnant is dangerous.
Right.
That being said, we don't have any randomized controlled trials showing that it's safer than not lifting either.
Yeah.
But at the same time, you would think that, I mean, people do weird things. Right? Like people do some strange sort of drugs and strange, over-the-counter stuff and get weird infection. Yeah, okay. Where are the case reports of woman squatting PR set of 5 with belt on, at 3 months, spontaneous, abortion or, threatened abort, none of that stuff exists.
Right.
So I guess I would think that with the popularity of training now, particularly through CrossFit, I would expect some case report showing at least some risk profile, and we just haven't seen it. I mean, I get like not skiing. Don't go skiing because you might like crash.
High velocity crashes and things.
Yeah, like probably don't do burpees. But so a friend of mine, Mike, his wife just delivered. Like she pulled a PR triple a few days prior to delivering. Yeah, which is kind of cool.
She had help. That's cheating.
Did she have help?
Yeah.
What do you mean?
Maybe. Two people lifting.
Oh yeah.
It's a team.
2 are lifting for 1, right? It's a team deadlift.
Tandem deadlift.
Lifting for 2.
It's cheating.
That's a great shirt. Copyright. Don't anybody take that. That's my copyright. Lifting for 2.
Yeah.
Yeah. Barbell OB. But anyway, and I think he said that she delivered in 5 pushes. So
that's awesome.
1 set of 5. Now. Okay. What's more frustrating to you when women, because I assume most of your patients are women, when they say to you, I don't want to get big and bulky from lifting weights, so I don't want to lift weights, or that they prefer to just stick to cardio. It's the same. It's basically the same thing, but like which one is more frustrating to you as a practitioner?
That's hard to tease out because they do commonly come from the same mouth. I would say the big and bulky statement is more frustrating to me because the
some people
the declaration of wanting to just do cardio tells me, hey, you have some level of physical activity that is more than the sedentary person, and I'm not going to try to dictate what you should do, and you're motivated, so sure, do that. But to specifically say that they do not want to strength train because they're going to get big and bulky, I just feel like, open your eyes, like I'm sitting right in front of you. Look at me. Am I a big and bulky person? Do you know what I can do? And I am a normal looking female, I think. What do you think? But anyways, normal looking aside, forget I said that. Really, it's just so much ignorance there in that statement. To try to convey to someone that they do not possess the level of testosterone necessary to develop masculine features. It's a whole physiology lecture, and it's so frustrating because I'm not going to sit down and break it down for them. And it is just such a statement of ignorance that probably frustrates me more.
Yeah. Well, I certainly can understand that. Now, I will play devil's advocate
Go
for
on.
a second. There is likely a certain cohort of females who do, in fact, gain a significant amount of muscle mass from training. but I want them to identify themselves. Now, I don't think it's a lot by definition, because these are outliers. These are the freaks of the freaks, right? These are the females who they touch a barbell and like through appropriate strength and conditioning and do notice like a significant amount of muscle mass gain. But these are the ones who are going to be the freaky athletes. And I would actually say that if we put you guys out on a continuum, that you're probably towards that end. Now, obviously, I agree that you're not, big and bulky, and you don't have the chemical milieu inside of yourself to
favorite word.
Milieu. Well, me and Claude Bernard hang out, to look that way. And I think the fear is that they don't want to look like a professional female bodybuilder, who's taken, specific substances to look a certain way. But I do think that there is a cohort of female who do, in fact, lift weights and get bulkier. But I want them to identify themselves so that I can coach them.
Yeah, and send them to the games.
Yeah, exactly. So
I agree with you, and they are the minority.
Absolutely.
But if someone's going to use that as an argument in that context, I'm just going to choose my battles, because I can't dictate what someone's going to care about. And what someone cares about is how they look in the end, there's nothing that I can really say to convince them that their health and being stronger should take priority to how they look.
Sure. Well, and the other thing is too, like, easy way to not get big and bulky from lifting is to not be in a caloric surplus. Just easy way. Hey, you don't want to gain any muscle mass.
That's just like one other thing to mention in addition to everything else.
Yeah, exactly. Like if you aren't gaining weight, guess what you're not doing? You're not gaining muscle mass. And I know that gives me, people on the internet they hate that. They're like, hey man, I just bought this ebook that told me I could get lean and jacked at the same time, and bigger muscle at the same time. It's like, yeah, well, they are preying on your inability to tease out the truth. So.
Yeah.
All right. Well, I like that answer. All right. Question to you, Dr. Baraki, male. Hey, what book or books do you recommend for someone wanting to learn about programming and lifting in general? Obviously, besides Starting Strength and Practical Programming.
Besides those two.
Mm-hmm.
So, assuming this person has actually read those and actually digested them, because I will make the argument that they require multiple reads to fully absorb.
100% agree.
I think I read the Blue Book probably three times, I think, before I went to the seminar for the first time, give or take. Mm-hmm. That's a good place. Those are definitely a good place to start. So if you've not read it more than once, your first instruction is to go back and read them again. Perhaps this is a reasonable time to announce the next thing. It's not necessarily going to be super widely published in hardback or something like that. But Jordan and I have thrown together a little ebook associated with our quote unquote the Bridge program that we're going to start to recommend for people.
Take them to the Bridge.
Of an appropriate demographic and training history, who will then be able to use the program as they come off of the novice linear progression. And so there's going to be an ebook associated with that will basically explain a whole lot of the underlying programming theory behind why it looks the way it does, and then it can hopefully provide a framework for kind of where to go next in training.
Yep. Yeah, I would actually argue that those people who are asking about what are the next books don't actually understand the books that well. And I don't mean to be on my high horse, but it's kind of like, look, my next recommendations are going to be more peripheral tangential books, Bondarchuk, Bompa and Half, Isserin, Zetsursky, but you cannot actually understand those books in any sort of practical context until you could legitimately. Someone could give you a topic from practical programming and you could just recite, hey, this is what this means and this is, all the considerations. Because when you read a paragraph from Zetsursky's Science and Practice of Strength and Conditioning, you're like, oh my God, what did he just say? You can't even read the damn thing.
Right. That's why I've completely, the books that you mentioned, those are the ones that the titles of which are typically thrown around a lot in these sorts of discussions. I've basically stopped recommending those to people who ask me what books they should read next, because it's like, if you're asking me what books you should read next, you're not ready for those yet.
Yeah, I almost
So your instruction is to go back and read the basic ones again, and when you're ready to read those ones, you'll probably find them on your own.
You'll have come across them. Yeah.
Yes, exactly.
That's probably a good point.
Yeah.
Lorraine, what are you reading now? Not right now, because it's not, some OB text.
Practice bulletins.
Oh, God.
Yeah,
You know what I miss about practice bulletins?
nothing.
Nothing.
You don't miss them at all.
Yeah. Oh, nine. Join us next time for our Barbell Medicine OB workout plan. We'll be releasing those templates shortly. No, I'm just kidding.
I told her after she does a bunch of Eurogyne stuff this year that we'll have her back on the podcast and we can talk about that kind of stuff because people want to know these things.
Let's take them to the pelvic floor.
Let's enter the perineum. Let's not. Okay.
Oh, God.
Let's not. Next question. Is adrenal fatigue real? No. And if so, how would it affect training and programming? Well, I'll take this first one. It would affect training and programming if you saw a practitioner who believed in adrenal fatigue and they would subsequently modify your training and programming to be ineffective, have you take a bunch of bullshit supplements, and then months would go by, you'd feel no better because you're just undertrained. And something, if you're actually tired, right, and you have no medical cause for it, such as like an arousal syndrome at night, or you're not sleeping enough, or you have sleep apnea, or you have some other
number of other things, anemia, hypothyroidism, hypogonadism, other endocrinopathies, like all kinds of stuff, renal failure, cirrhosis, hypercalcemia.
Right. Like we could legitimately go through systems. Yes. Then, adrenal insufficiency, here's how it presents. Your blood pressure is super low. Your blood sugar is poorly regulated. Sometimes you get a little brown, right? Like
depending on where the lesion is.
Yeah, a bunch of weird things. But you're
vomiting.
Yeah. People are like, I'm just tired. I'm like, well, maybe you're depressed.
Mm-hmm.
Right? So black licorice root's not going to cure that. Okay? The Poliquin pregnenolone isn't going to cure that, and I would say that who the hell are these people recommending you take potentially steroidogenic supplements with no basis to test this stuff? Not the mindset to understand how this actually affects the body. So shame on you people for actually making this a thing, posting about it on the internet, and parading around like you can fix it. It's great that you made up something that has a financial benefit for you, all right, and that can't be tested for reliably. This is like the reverse T3 syndrome kind of thing. When I see reverse T3 panel on an outpatient, exactly. Yeah, for an outpatient set of labs, I just laugh. I just know that the person who ordered the labs is an actual idiot, and then I'm like, look, man, I have so much work to undo here because you've sat in a professional's office who told you that you may have this thing that has no cure, that they can, it's just frustrating. So these are the people who need to have access to UpToDate, where you just type in adrenal insufficiency, and then the first thing that comes up is adrenal insufficiency is not a thing according to the American Endocrinology Society.
Adrenal fatigue.
Yeah, and then you're right, and then they have this huge practice bulletin where you can just read through and say, oh wow, maybe this person was just lying to me after they adjusted my neck.
See what you did there.
Feigenbaum goes off. Look, I'm looking into my very expensive camera right now. If your practitioner tells you that you have adrenal fatigue, get a new practitioner. They are not licensed to practice medicine, and if they are, that it should be revoked. Don't take anything that person tells you to do. Don't let them touch your neck, all right? And don't take the supplements. You need to see an actual doctor, all right?
Dad's mad.